It is my pleasure to introduce someone you probably know, and that is Robyn Wolkofsky, our longtime physician assistant. Many of you have worked with her, and she is going to introduce two of the newest members of the Memory Movement Charlotte staff, and we'll talk a little bit about what physician assistants do.
Hi, everybody. Thanks so much for joining us. We're excited to do this new model and get to see some favorite faces in person and the rest of you on screen. So we really appreciate the interest, and feel free, as Melanie said, to let us know what you want to hear more about. Just a little bit background of myself. I don't know all of you. I see names that I have not had the pleasure of meeting yet, some of you, but I've been here since Dr. Edwards, since 3 weeks after he opened his door. So I can't say since the beginning, but since pretty close to it. And I knew him for a long time before that through working in the hospitals, and was very excited when we had the opportunity to work together. So it's been an amazing almost 9 years, I think. And so, but it's grown so much. And I've been kind of the only advanced practice provider the whole time. And now, as of last year, we had Heather, our nurse practitioner, who's on leave right now and coming back in January. She joined our team, and we have our two wonderful newer PAs here. They're not new PAs, they're just new to us, but we are super excited to have Johnnie and Jessie. It's been so much fun, and I'm super excited that we have a whole team of us now to keep these doctors in line, if you know what I mean. So if you guys could tell us a little bit about yourself and your background, that would be awesome. Jessie, I'll start with you since you've been here the longest.
I'm Jessie Hoskins. I worked in internal medicine before joining Memory Movement Charlotte. I went to a PA school at Wake Forest and undergrad at Boston College, and I'm really excited to be here.
Hi, I'm Johnnie, Waataja. I'm a physician assistant in neurology for the last 17 years, or actually for the last 11 years, but I did neurology as a fresh grad. And in between, I've done some family medicine. I did graduate from Wake Forest also, many years before Jessie. And I went to undergrad in Greensboro at a little Quaker school, Guilford College.
Start with, what does a PA do? And then what does a PA do at Memory and Movement? How is it different?
You guys want to take it? Go ahead.
Well, physician assistant can perform many of the same duties that your physician does. And we are trained not quite as long as your physician is. We do have to go into our program with 1,000 hours of clinical experience prior to being admitted to the programs. I think that's still true. And once you are in the program, then you're generally trained in all areas of medicine, and some are actually trained in surgery as well. And then we do about 18 months of our 28-month schooling in clinical rotation. So we get firsthand experience in all kinds of areas, and that allows us then, as we get into our careers, to practice in various areas of medicine. In addition to that, we are certified in all areas of medicine and are retested and are every 6 to 10 years, depending on which route you take to be tested. So we have to keep up with the latest and newest medical technology and diagnoses and treatments and whatnot. And we continue to do continuing medical education. Once we become hired in a particular area of medicine, we do get some specialized training, certifications such as the MOCA certification. And then there's some other things that might interest us that we can pursue and become a little bit more advanced in our careers. Does that help cover it?
Yeah, we work as a team with physicians and nurses and medical assistants to support patients and their families. But we are able to do just about, we can be trained to do anything really a physician does, as long as we work with someone who's trained to do that. So yeah. We're not going to be operating over here. That's not what we do. But PAs can be, obviously in surgery and general practice, dermatology, psychiatry, anything.
Yeah. And then memory and movement, every practice utilizes PAs a little bit differently. And in our practice, we are doing patient visits. Typically, we're seeing in our new model that we introduced a couple of years ago, we are doing the first visit that occurs about 3 to 4 weeks before the second visit, which is with the physician. So that enables us to have a 2-hour visit and introduce the practice and get a really detailed introduction to the family, to the patient, their needs, do a lot of screenings and collect a whole bunch of information so that we can have all of the records, initial tests, medical history in detail, and everything really that the physician's going to need a few weeks later to kind of dive into further diagnostics and treatment plans. And so we can assess, and we do a physical exam, we do interviews with patient and family, cognitive testing, mental health screenings, safety assessments, and then we come up with an assessment and initial plan. And then we let you see your physicians in a few weeks after we've spoken to them and presented your case. Sometimes we have team meetings about certain situations and put our minds together. And then after that, we alternate and see you in follow-up visits. We'd like to see you, every other visit if the schedules work out with the physician so that we can all keep our hands on you. And in between, we talk to each other. And we do something called care plans. And we'll talk a little more about that later. But care plan is a particular visit that we really enjoy doing and work with our social worker on that. So and aside from that, we do education and other activities around the practice, but that's the main part of patient care. We respond to your cases and portal messages and those kind of things. So hope that gives you a little bit of an idea.
And you really do keep the doctors on their toes.
We try. That takes a village, not just that.
All right. So we have a long list of questions that have already been submitted here. We'll jump right in. And if you have others, as we go, just put them in the chat box or raise your hand wildly and turn your microphone on. Okay. All right. This one's from Robyn, I think. When a family member with cognitive decline is very emotional and upset about something that doesn't seem like a big deal to the caregiver, how can you validate feelings and help them feel better in the moment and alleviate distress without seeming fake or belittling? That's a tough one.
Yeah, it's a tough one. These are really hard situations. It's a great question. And it is extremely difficult when someone is having cognitive issues that you love, who you've had this kind of partnership and this dynamic of communication all these years, and then all of a sudden one of you can't communicate on the same, on the same wavelength. And so it really puts, whether it be the spouse or the child or the friend, in a really difficult position because they want to be as honest and straightforward with the person who's having some difficulties as possible. And oftentimes it feels very they feel guilty or dishonest by not answering a question correctly. If the correct answer would either upset their partner, if they couldn't understand the complexity of it or something like that. So we really do run into this a lot. Sometimes people want to, feel like they're even having a false need to go somewhere, find their home or go somewhere else. And that can be really distressing to the patient and extremely distressing to the family. So we have a couple of approaches that we've learned over the years, mainly from working with families and seeing what people respond to. And we call it coming towards the patients. And so we're really focused on their quality, sense of calm, reducing agitation and fear. And by trying to recorrect and reorient people to what really is true, that oftentimes can lead to higher levels of anxiety. So what we try to do is kind of go more towards where they are. And so if someone's having super mild memory loss, that's not really what I'm referring to. That's pretty, we kind of gravitate towards that. We should still try not to correct people and say, well, don't you remember? We try not to do that. We just kind of move forward with the conversation and reassure. But if we're really trying to, if someone says, I must go catch that flight, I have to go. It's hard to miss the flight. We may suggest saying, instead of we don't have a flight, say, I know, what does it feel like when remember that time we were late when we tried to take that trip, to the Grand Canyon, and kind of go down the path. They're thinking about a flight, they're thinking about getting to the airport. And maybe we can kind of delve into a conversation that they could feel some closure on. We're not trying to tell them they don't have a flight. We're trying to say, gosh, it's really hard when you want to get to that plane. They're always delayed these days. Kind of spinning it a little bit where it's a redirection, but it's still not telling them you're not correct. I don't know if you would mind me sharing a technique. Would that be okay?
Sure. Oh, no.
We have a wonderful technique that we've used from one of our long time patients, Bill, and he felt like he had a flight to catch. And the creative solution that his wife, Chris, came up with was to have one of his colleagues call him in the afternoon, correct me if I'm telling this wrong, and say, the meeting's been canceled. We don't have the meeting today. And that was just enough to kind of settle him because he didn't want to be late for the meeting. And so rather than people saying there's no meeting, that was years ago, that doesn't help anyone. And so just by putting a friend into that role, it enabled the family to have support, enabled him to feel closure, and there was no harm, no foul because he was safe at home. So those kind of creative techniques can be really helpful. And not feeling guilty about telling something that's not true is very helpful to allow yourself to do.
Did you want to add anything to that, Chris?
Well, just saying that, we're taught not to lie, and I started to lie to my teeth, but it was exactly what I needed to be doing to minimize the anxiety and the stress, and I did that.
Yeah.
And it was not my normal way of behaving, so it was a little bit of an adjustment, but it certainly worked.
Your anxiety or his?
Well, mine, his too, of course. That seemed to, give him some calm versus struggling about getting to the airport and all that. So it was a win-win for both of us, really. Yeah,
it's a good solution. All right, back to our questions. And if anyone has any other questions as we go or anything to add, please throw it in the chat. We're monitoring that. Okay, somebody asked, maybe Johnnie can take this one. How do you keep your loved one, actually, did we write Johnnie or Jessie? I think we wrote Jessie. How do you keep your loved one in a social environment when adult daycare is very, very expensive?
That's also a hard question because caretaking is incredibly expensive. If you're not paying someone to come or paying to have them go somewhere, you're taking time off of work. And you're not making it. There's a cost somewhere. So depending also on the patient and where they are and their abilities, there are senior centers locally, the JCC. There's always options to look for to help, but definitely based on where the patient is on their level of, taking care of themselves, hygiene, like toileting, we look at different options. But if that is a struggle, we talked about the care plans briefly. We have a social worker on staff who can help find resources in your area. I know where patients are all over the Carolinas, but we can help you find resources in your area that are lower cost and accessible.
I'll just add that every county has a council on aging that is a wealth of resources. I think that it should be a field trip for all of us, no matter if we're healthy or have struggles. But it's a great thing to look up your, Mecklenburg County Council on Aging, for example, York County, Cabarrus County, but they are incredible. And so they have listings of lots and lots of activities in the area, calendars of things, resources. So that's a first stop that I usually recommend too.
Okay, so that kind of leads us to this question. Johnnie, maybe you can take this one. What are some strategies that you use to connect caregivers with resources?
So I haven't been here very long, but I have. Yeah. But I have been able to sit in with on a care plan. That is something that MMC will host with one of the PAs and our medical social worker. In order, I think there are some restrictions or some guidelines on who and what we discuss, but typically at that time, we can talk about the stresses or the caregivers are going through, some needs that the caregiver as well as the patient needs. And at that time, we can also just kind of focus on the caregiving part of this and making sure, you know, that you feel comfortable and safe with your loved one. The other option, you can definitely contact us through the portal, and we can talk about resources that are available by cases.
No, and during your visits, a lot of what we cover in the care plan is kind of piecemeal tailored to your concerns at that visit. So if you come with a couple of bullet points, the main stressors, that's always helpful to kind of make sure that you get what you need while you're here. And we try to have alone time for you, for the patient to express their thoughts alone and privately with us, and also for their care partner or caregiver. And if you don't encounter time alone at that visit, or if you know you need it, please ask the nurse or whoever's bringing you back, and we'll make sure you get it. But yeah.
Also, there's the Take Charge library.
Yeah.
Whenever you're at home and find yourself with a middle of the night question, it's always worth a look. That's on our website under education. Okay. Jessie, let's go back to you. How do you feel about, I know you have a very well-rounded background. How do you feel about music therapy for both movement and memory patients?
So my belief, for my personal belief, for most therapy, speech therapy, occupational physical therapy, music, it's beneficial and it's really low risk for harm, right? And there can be great benefits. A retroactive study was done in 2019 looking at a bunch of different dementia and music therapy studies. And they did see some benefit in cognitive improvement because the music pathway in the brain is a different one than the verbal pathway. So some patients who have trouble like verbally expressing themselves may have some benefit being able to express themselves through music. It's using a different part of the brain, different way of communicating. It's a different language, if you will. Like I read music and I read words, but they're different. So there are actual music therapists, is what they do. There's not been a very well-designed study just on dementia and cognitive things in music therapy. I'd be interested to see one come out, but I think there could be great benefit. I think music is calming, and all humans have kind of a desire to connect through music. So I don't think it's a bad idea at all to look into music therapy.
I'll add a personal story. My dad was a musician, and when his Alzheimer's became very advanced, he was really having a hard time with words, but he never forgot how to play the piano. And at the piano, he remembered the words to every song.
Sure.
Yeah, it was like kind of crazy.
I think music connects in a different way. You know,
It's yeah, and there's the I don't know if you've heard of Music in Memory, but that's a program that is in some of the long-term care facilities, and where they come up with one idea that's been shown to really help people's sense of calm and enjoyment is creating a personalized playlist. And we did this during COVID. We did some happy hours and we got our patients' favorite songs. But the idea is that you think of a song that reminds you of a happy moment of childhood, one from your wedding day, one from school, college, a vacation, and you put these familiar memory triggering songs on a playlist, like on an iPad, and people really resonate with them. That was great. And then the one other thing that I've seen online that maybe we can post a link of is there's a Parkinson's, there's a lot that happens with movement and music. And there's even, there are apps with metronome ticking that some people will find it easier to walk to the beat of a metronome. And there's also a video online of a physical therapist who had a patient who had much, much difficulty with freezing gait, could not take steps. Once they got the beat of the music going, was walking and dancing. I mean, it's just like the most wonderful thing. So we can put a couple of links online to show you that, but it's definitely, I think it's a great.
We'll
Great
track those
concept.
down, and when this recording is posted, we'll put the links beside it.
Yeah, and we'd love to have a workshop of it here. So maybe one day.
Okay.
That would be fun.
Okay.
Making a note to ask Robyn for those links later.
Okay.
Okay. Okay, Robyn, here's one for you. How do you initiate and convince a patient to accept a caregiver coming into the home to assist if there's just one caregiver and that person needs a little time away from caregiving?
Yeah, this is probably one of the biggest things that we get asked about, because this is often, a point where it hasn't necessarily been discussed between, let's say, as a couple, and we're at a point where one person has been, they've been care partners, and now it's shifting a little bit where there's more caregiving going on and people are starting to become fatigued. And we know so much about caregiver stress and what that does to a person's health. We also know that caregivers who are exhausted tend to become ill and also can't then be their best selves for their loved one. And it can jeopardize their loved one's care or ability to continue as things are. So that's why we're always trying to focus on both the patient and the caregiver, because really both of those are good for both of them. So as far as bringing in help, it's different for everyone based on the level of physical and cognitive needs. Some people can be a part of the conversation, and we would much rather have these discussions when everyone can express their preferences, can have some say. Can we meet somebody who can become kind of a bit of an extended family member, just in case I had to, if I was the caregiver, if I had a few days where I had to stay in bed and needed someone to come in and clean up a little bit or make us a couple of meals, maybe we can get to know someone in the community to do that. If there's any way to bring someone in before it's a crisis, I think that's a great way to just kind of think about expanding our circle just a little bit. And even trying it can reduce the anxiety about putting it into place later. Sometimes we think it's going to be horrific and it isn't. So those are, there are very different ways to do it. Sometimes we don't have a choice and we're at a breaking point and we need to do it. And then we see how we adjust. And that often goes better than we think it will. So, we kind of assess the need, the health of everybody and how much we can all be part of the conversation before we give you kind of guidance on what how to introduce it. But gradually and bringing people in. The other way we often have a lot of willingness to work with someone is if it's not necessarily someone who's an aide, okay, or like a nursing aide in a white coat with, the signs, this is from a nursing agency, but more of someone who has nursing experience that may be almost someone who can be a personal trainer in the home, okay? Maybe they're not official personal trainer, but maybe there's someone who is a retired gym teacher in the community that you live in, right? And they can come in and maybe take someone walking or go, maybe it's a housekeeper that you have who wouldn't mind a couple of more hours during the week and could be there to supervise while you go out to the store. We had a wonderfully creative solution by a family the daughter had her own person who helped around like a nanny for her children, who was also a personal assistant and could run errands. And she told her mom that the nanny could use a couple of more hours a week. She didn't have enough work for her. So if she wouldn't mind her coming over for a couple of hours, that would enable this woman to get paid for those hours. And the mom thought that was a fantastic idea. She felt like she was helping this nice young woman and everybody, got a little break. So we use creative ways to bridge it so it doesn't feel threatening. Those are some options that come to mind, but yeah. If there's anything else you can think of to add, or if you have any ideas,
just the Ivy, as many of you know, and there are other. I have somebody I've been working with who's it's in a different county, and they have an adult daycare, so they're around.
Yes,
and they have been very pleased, and I think the caregiver has just really come to terms with that, and it's much more relaxed. So,
sometimes taking a leap
is
not as scary once you do it.
Yeah.
When I was caring for my husband, when he was home, obviously his take was that he absolutely did not need somebody, to be there. And at that time I was, was using more of a companion. That would then allow me to get some, free time. And I used the approach that I understood he really did not need anyone, but that I did. I needed somebody, that would ensure that he was okay, and then allow me, okay, to relax enough and enjoy my time, out and about. So I reassured him, I understand you don't need somebody, but I do.
That's good.
And
Good for you.
he never 100% accepted it. Okay. He continued that, no, he does not need someone there, sitting, but he at least allowed it. And I was able then, on a weekly basis to, get out.
That's great. Yeah. There's a few questions in the chat. Just starting with the first one. I plan to take my sister, who is 69, and her husband, who's 85, on a cruise this February for their anniversary. She has an Alzheimer's diagnosis since January. She still has the ability to do her own daily living activities, but struggles with her short-term memory, sense of direction, and math. Any advice in making this successful, as it may be her last trip? Thoughts?
That's a tough one, isn't it? Because I found, and I don't mean just to be discouraging, because there's probably a great way to do this, but I found with my spouse, he was so confused when he went on a trip. So I'd like to think that it could work for her. And I don't mean to be discouraging, but it would not work for me, to be honest with you.
If anyone on Zoom has suggestions, feel free to jump in.
Go ahead.
I was just gonna say, I think that keeping a schedule similar to what you have at home would be helpful. And then also bringing along some things from home, such as a portrait of family members or their favorite robe or things like that could help.
That's a great
That's a
idea.
good idea.
I like that familiarity.
Yeah, that's it.
And travel of any kind tends to wear everybody out and also get, we don't drink enough fluids. And so planning fluids and snacks, taking enough supply with you, anticipate delays and lower expectations. The trip won't be the same as the last cruise. So really just knowing that, your sister may be able to do one activity that day, and then it's going back to lie down or lying on a lounge chair and relaxing, as opposed to trying to push too much. And that way, you can kind of bend and weave. The other thing that's so important when you travel, when you're in a different location, is the risk of getting disoriented and lost is huge. And so I always recommend that people have ID bracelets before a trip, and even consider GPS type pendants. But no, everyone should be supervised fully, because when you go into a place that you're not familiar with, even if you come out of a restroom, you think that you were supposed to go one way and your family might have said, wait at this chair. And so really, I think eyes on somebody the whole time is so important. So just really thinking about that before, make sure you're all safe.
Anyone have anything to add to that? Any recent travelers? Another question in the chat box, along the same lines, how do you encourage a parent to make that first doctor's appointment related to memory loss? My 85-year-old dad thinks his memory loss is not an issue because he can remember things from his childhood. You're welcome, Michelle.
Unfortunately, short-term memory is the first to go into those longer-term memories are preserved in certain dementias. So I think just the encouragement, instead of focusing on you have a problem, you need help, is saying, I'm concerned that this isn't what it used to be. Let's get an evaluation to make sure that you're fine. Let's make sure we're doing everything we can to keep you healthy, but make it more as a positive spin and not you don't remember and arguing, but kind of create a team of you guys working together to kind of encourage them to make that first step. It's scary to think, is something wrong? And like everyone's afraid of that diagnosis, of that kind of that issue, and seeing the decline that may be ahead of them. So just being very supportive and a team together.
I don't know if either of you have a suggestion on that. I mean, I think that we get this a lot. And so a lot of people are afraid to come It is not uncommon. And so, I think that, expressing concern and reassuring people that you're here for them, especially if they sense something is wrong. If they really don't think anything is wrong, then approaching it, I like your approach, Jessie, like from a brain health perspective. As we age, we do a lot of things to prevent, brain issues. So just knowing that all is good and how can we keep sharp as we age and keep safe and prevent health issues, that could be another way to come. And I do have a few couples who have come where one spouse kind of made their own appointment first and said, let's do this together. I'll go first because you never know what's going on. Let me just get a check on my brain health. And then someone came the next week and we did separate. And so
I know what we did was we had a family meeting. So my sons were there and me. And all I wanted was for Bill to say, yes, I will go to the doctor. And what he did was we said it in a very loving way that we're just concerned. And we wanted him, and he was just being very defensive. And then finally we said, we would just like you to do it for us. And he said, I'll go. So,
and that's the same tactic that worked for Help in the Home.
Yes.
Do it for me,
Yeah. And I don't think I even, the loss of memory or just any mention of brain health or anything like that. I mean, it's scary for everybody. So I don't think that to get my husband, I did not even focus on the brain or the memory. It's just not another, he was very accustomed to going to a lot of doctors. So that helped. Okay. And it was like, no, we're just going to another doctor. All right. And to this day, even though he sees Dr. Edwards regularly, he doesn't remember, of course. And, but, rather than focusing on, we need to find out, get you checked out. Something's definitely wrong. Yeah. So that may help.
Along that same lines, you may be able to incorporate your primary care physician or provider to also how to kind of help make that happen. And maybe not mention, exactly what's needed, but maybe we should just do this as part of our preventative program. Rather than saying.
Yeah. And we do assess, gait and walking and balance and movement. And so, sometimes people come for other issues and we do a full evaluation on everybody. So that can sometimes, people are more willing to come in and make sure they can keep walking more steadily.
Yeah. Do you find that a lot of new patients know that there's some memory issue and they just kind of aren't ready to really know it, to have you confirm it?
Yeah. Answer.
Probably about half and half.
Yeah.
Likely.
It's going to be terrifying.
Sometimes they truly, they don't know anything's wrong. And that's actually, I think, the most difficult, especially for the families, because they're kind of refusing any sort of help or support because nothing is wrong. They truly, they don't know anything's wrong. But then some, I'm fine. No memory. I mean, I'm old. It's fine. What do you expect? But they really are having some deficits. And then some are like, something's different. My brain is working like it should. I can't speak like I used to. Something's wrong. And I don't want to know what's going on. Can we fix it? Can we get better? Can we preserve things? So it's about half and half for what my recent experience has been.
How do you get through the denial part of that?
Well, it's
Carefully.
Yeah. It's carefully.
Sure you do.
We try to sort out, we see denial and fear. And then we see there's actually a symptom called anosognosia, which is a very long word that means lack of insight. And that's a part of the disease in some people's brain. And so we oftentimes, families will think someone's in denial and resistant and difficult when in fact they literally cannot understand, because there's like this process going on in the brain that there's nothing we can do to make them believe it's just not reality. And it just brings more anger and more anger. So we really try to sort that out. And when families can understand which it is, and then we can kind of take a tactic to deal with it. Because if it's the anosognosia one, there's a lot less rational discussion that we can do. It just can't happen. So we have to kind of think about how to move forward and keep someone safe, even though they may not understand it.
Yeah.
If it's more denial, we build rapport.
Yeah.
We work with you over time, and people usually after the first visit or two feel very welcomed and warm, and it becomes much less scary. The blood pressures go down, anxieties are down, and it becomes a little more of a welcoming place that they don't feel so threatened. And so sometimes it just takes some time.
Yeah.
Let's see. Back here. A conversation opener could be. A conversation opener could be, I know you haven't been feeling quite like yourself lately. That's a good
Yeah,
one. I love that.
again.
Okay, my husband is afraid to leave the house due to incontinence. I have an emergency bag, but that doesn't ease his fears. Do you have any suggestions?
Let's see. We're going to come up with strategies on the spot. I mean, a toileting regimen, if it's bowel movement incontinence, sometimes there are ways to adjust medicine. So the timing of things works a little more at a certain time of day. There may be a way to, sometimes if people have very frequent stools, for example, I used to work in GI, so forgive me for going down a little rabbit hole, but if people have very frequent stools and they have an important event coming, sometimes we would say, a tablet of Imodium could be a fine thing. Discuss it with your physician. I wouldn't give you any medical advice over the Zoom, but sometimes that can be a way to be able to get through an event without as much fear, if they would, feel better about that. Also just taking some breaks to allow them longer time in the bathroom during the outing. But it can be, and also baby stepping it, really staying very, very close to home. And sometimes if it's just anxiety and there's not likely to be a problem, it's more about the worry of there being a problem. You may be able to do going next door, going to sit outside in lawn chairs for a little while, going to take a drive around the block and back, and just kind of doing a fast food drive-through, just making it really small and see if that helps get more comfortable.
Anyone else? Okay, we have one question that I've been dying to ask of all of you, which came in from one of you. I don't know who, somebody who registered. What trends are you seeing in the patients that you see? What are the biggest challenges caregivers are experiencing, and how are they managing all the stress?
Great question. I don't know who asked that, but that was really interesting.
The biggest trend I'm seeing is kind of the impact of social isolation far from the pandemic. I think people say it got worse during COVID. I noticed more during COVID. It could just be the timing, but I think the impact on the brain of that lack of socialization is really the trend I'm seeing for communication.
Absolutely. Absolutely. People have noticed a big decline. In the beginning of COVID, it was really interesting because as things shut down, I found a lot of our caregivers were saying things are easier, because it was almost like the busyness of life that can be very agitating kind of stopped. And they were together all the time and we were home all the time. There was a lot of structure. And then as it got prolonged and people became fatigued and didn't have any of the coping skills, like even getting out to go to the grocery store to decompress for an hour, was ripped away from people. And so it really took such a huge toll. And now getting out again and re-entry has been extremely difficult, anxiety provoking, especially for our patients who are just, have really kind of had a setback in social anxiety, and so it's been really, really difficult. And then also a lot of places are still closed. A lot of support groups went online and not in person. That doesn't work for everybody. A lot of, adult day programs shut down, gyms, and so after 2 years of, we're now 2 years older, we have 2 years more decline to deal with, and now to kind of re-find new things to work, it's really exhausting. So it's been inordinately difficult.
I think kind of tail ending on that, the kind of nonstop stress, we're seeing more burnout for caregivers, especially just because the inability for those daycares, the social networks, the support, that just kind of complete exhaustion and fatigue from all the things in life piling on them. I think we're unfortunately seeing that trend as well.
I don't have a lot of experience here at MMC, but just from my observation, I see the need for memory care is increasing, and that makes me think that maybe it's more publicly accepted as something that we're going to reach for help and for caregivers as well as our loved ones.
Yeah, we are more open to talking about mental health and the effects of isolation. And so that's enabled us to talk, more freely, I think, as a community about it.
Yeah.
So there's been so much in the news. So it really has opened some conversations that otherwise were more difficult.
I have one last question that we never asked you all in the beginning. Probably should have. Robyn's been with us for a long time, so I don't think anything surprises you anymore. But or maybe
That's
it
true.
But Johnnie and Jessie, I'd love to know what brought you to Memory and Movement, because you both had careers elsewhere. And what has surprised you the most in the short time you've been here? Do you want to go first?
Sure. So what brought me here, I'll give a brief answer, is kind of the opportunity presented itself. And when I came to shadow and see what this practice was about, I was blown away by the care and truly the compassion and the love for the patients and their families. I'd never seen a medical practice where there was that emphasis on the entire person and their family in front of them, and the resources put behind them to support them and to support us supporting them. So I thought it was just an incredible opportunity, a unicorn, I called it. To people, I was like, I found a unicorn. I didn't know this existed. It's magical. So that's why I joined. And then what has surprised me?
I mean, a unicorn surprising on its own.
I mean,
It is.
let me think on that and let you say what you
I will just ditto everything you just said. I was just blown away when I learned of this clinic and the different approach to patient care, including the caregivers, and just spending so much time providing compassion and finding ways for the whole family group or the whole caregiving group to make this journey together and make it at least somewhat doable. I was just blown away as well. I don't like the term because I was just floored or blown away. And the guys, the whole team, the whole clinic is just so compassionate and so friendly. And it's surprising because you don't see that in a lot of medical groups.
I'm glad you guys are here.
Me too.
Very glad. It's really it's wonderful that the practice has grown to, in the last 2 months, triple its PA capacity in this way. And welcome to both of you. This was a wonderful opportunity to get to know you a little bit more deeply.